those pages and you're gonna be golden. Like that's all you need to know. That's all you need to know. It's right here, okay? So I'm gonna read it. We've done this like 100,000 times, right? But I'm gonna read it regardless because I want to show you that whatever I'm reading, we're gonna show you, and then you're gonna trust me to trust those pages. Make sense? Mm-hmm. All right. So elbow extension flexion. Why we are starting with elbow, which is in the middle of the upper extremity? Well, because it's the easiest to show. Honestly, it's the easiest to show. So we're gonna start with the elbow, and then we're gonna go back to shoulder and then down. Okay? So patient in one more thing I have to add before we start. We are going to teach you how to do measurements on quote unquote normal individuals. We're not going to show you any abnormalities. Why? Because it's too many of them. This course would never end. Like literally never end. If you're gonna give us scenarios and we go through those scenarios, this course will never end. So what's the solution? Solution is fairly simple. We're gonna show you how to do it on normal individuals. What we should see in healthy individuals. And then it's gonna be your responsibility to adapt that to abnormal situations or patients who are actual patients and have difficult times with range of motion, or they are weak. You're gonna have that baseline, what we were talking several times already about this baseline. That's what we are giving you. We're giving you the baseline. Once you know this and once you master this, it's gonna be your professional judgment to take this information and adapt to your real patients. Am I making sense? Mm-hmm. Otherwise, we're just never gonna finish this course, period, right? You're gonna tell me, oh, what would happen if the person is stroke? Oh, complete paralysis. Oh, what would happen if it's a partial paralysis? We can go like this forever, right? It's just not feasible. All right, so having said that, patients sitting or standing or laying down or sitting in the wheelchair, it doesn't matter. I just want you to understand that the position of the patient doesn't matter if you know what you're doing, okay? So sitting or standing for us over here, all right? So she chose to be sitting, and that's fine. We're gonna find the bony landmark. We have to find the bony landmark, otherwise we won't know where to put the goniometer. By the way, this is goniometer. So the stationary bar and movable bar and scale and fulcrum, those are like 4 major parts of the goniometer. Stationary bar, it's always 100% of the time the one which is attached to scale. So that's gonna be stationary. The movable bar, it's always the one which is not attached to scale. And just listen to the name, stationary, meaning we won't move it. The movable, we will move it, right? So just listen to the names. Fulcrum of the goniometer, it's that center of the scale, right? Fulcrum of the goniometer. So I'm referring to this as a fulcrum of the goniometer, and when we're talking about the joint, I'm referring to as what? Axis of rotation. Axis of rotation. Just to differentiate, okay? Axis of rotation, fulcrum of the goniometer. Although you might argue, well, this is axis of rotation for goniometer. Would you be wrong? No, you're absolutely right. But just to differentiate the terminology, if we're talking about fulcrum, it's going to be this. If we're talking about the axis of rotation, it's going to be joint. Okay? Semantics, really, means the same thing. Okay? You have a question? Oh, no. Okay, okay. So just remember, I have to, I'm going to show you how it should look like, and then I'm going to step on the side because otherwise you wouldn't see anything. Okay? So normally, for elbow, I would stand right here. Remember, nose and toes in the same direction, and I'm facing her. Not here, because I'm measuring the elbow, right? So I am facing what I'm measuring, and the nose and toes in the same direction. This is what I'm going to measure. However, you wouldn't see anything, so I have to move. But just so you know how to do it, okay? So that's a little bit the caveat to that. All right. So we're gonna find the bony landmark. What's the bony landmark? You have to know this. The lateral epicondyle, right? When her elbow is completely extended, remember elbow doesn't have neutral, does it? No, it doesn't, because that's extension. But what's that? Flexion. That's already flexion. Now, when we're talking about movement, then yes, she can go from flexion towards extension and stop over here. What was she doing? Well, she was going towards the extension, right? But if you judging or describing still picture as opposed to movement. This is still picture. She doesn't move. This is still picture. I'm taking picture, right? This is flexion or extension? Flexion. It's a flexion. Are you with me, guys? Yes. That's a flexion, because there is no other extension but this. This is extension. But not extension is flexion. This is little flexion. This is more flexion. This is max flexion. Nevertheless, it's flexion. Movement, yes, I'm going towards extension. But still picture, no, I'm flexing. By the way, for your project, for your paper, for that large assignment, I think I mentioned this, but you always have to go to the anatomical position. What did I tell you about the reference point? You must have reference point, right? If you don't have a reference point, how do you know where the body parts are? Well, now you do. This is your reference point, all right? So your project, your pictures, and the way you describe those pictures, always refer this as your point zero, as your reference point, okay? All right, awesome. So, how are we gonna find the lateral epicondyle? It's completely flat. And you can try on yourselves, by the way. Just do that and try to find the lateral epicondyle. And none of you, no, not like that. There we go. And none of you are going to find the lateral epicondyle. I promise you. Unless something wrong with you, but if not, you won't. All right? So how are we going to find the lateral epicondyle? Well, now you bend your elbow. Now you bend your elbow. And now it's very palpable. It's right here. Can you palpate on yourself? Look, you can see it. It's right here, right? But you have to palpate and you have to flex the elbow. All right, I found it. I got it. So this is my what? Axis of rotation. Very good. So now, in order to do the measurements, I'm going to ask her to extend it back. Extend it back. Look what happened to my finger. Right? What's happened to my finger? It went to the back. It completely changed plane of rotation. Now if I put the goniometer here, how am I going to measure the flexion? I'm not going to measure the flexion. Right? Are you with me? So the plane changed completely. Why? Because of the biomechanics. Biomechanically, bone shifted and shifted my lateral epicondyle all the way to the posterior side of the elbow. Well, that's not going to work for me. So I think we have only two. Yeah, I think so, right? Only two instances when you have to draw imaginary line. Okay, imaginary line. Now I have to caution you. Your eyes, I have to be with the joint. Okay, because otherwise you're going to draw the line like this or like that, but you're not going to draw parallel to the floor. The line must be parallel to the floor. So I'm going to go down. Now, my eyes are with the joint. Can you see that? With the joint. Now, I'm going to draw imaginary line parallel to the floor, meaning parallel to the floor, right here. Can you see that? Now I know that the lateral epicondyle must be here. I don't feel it anymore, but I know it's there. Why? Because it's right here. So it's just different angle, but it's right here. I know that. Okay, so I'm not gonna lose it. Keep that finger, because you're not gonna find it, or you have to start the process all over again. So don't lose it. Just keep your finger on it. Now we're gonna put the goniometer, right? So let's read. Place fulcrum of the goniometer on the axis of rotation, the stationary bar parallel to the midline of the humerus, and the movable bar parallel to the radius. So let's do that. Again.
You don't want any.
Yeah, that's what I was looking at. Thank you so much. Thank you. That was nice of you. Okay, that's much better. No, it's yours now. Yeah, it's yours now. Otherwise, it would be mine. So just slide it. Well, I like that one because it's already warm. All right, so I'm gonna put the fulcrum of the goniometer on the axis of rotation. And I know where is axis of rotation because I have my finger here, right? So now I look at it, I can take my finger away because now my fulcrum covers the axis of rotation, right? Stationary bar is parallel to the humerus. Movable bar, you see the one which is not attached to scale, is going to be parallel to the radius, and make sure that the position is correct, right? So preferably should be 0. Now I can kind of force her to 0. You okay? Okay, yeah, okay. So she is 0, right? Sometimes you have to kind of do that a little bit passively, unless you can't. If you can't, you can't, right? I could. It's 0. Can you see that? It's 0. But let's say somebody was stuck here, and you really can't fix that. You can't, like oh, no, don't do this, no, that hurts, right? So, okay, we're stuck. So now I have the measurement of what? Here it says 170. It says 170. It says 60. It says 350, 80, 10. Which one is it? 10. Right? 10. So you have to make sure that you're looking at the right scale, and it has to make sense. This is 90. This is 90, right? So this way it's going to be what?
More than 90.
Above 90, more than 90, but this way is going to be less than 90. This is 0. So this way must be more than 0, right? So it's 10, correct. Now, how are we going to document that 10?
Is it -10?
No.
No.
Just
Like
It's
that.
just 10, yes.
10 too.
In other words, it's a positive 10, but we're not going to put plus 10. We're just going to
Just
put
right
10. Now, why not negative? Because negative would mean, yes,
Hyperextension.
hyperextension, more than normal people would have, right? Correct, okay. So we got our 0, yes? Okay, what we're gonna do now? Well, we got our first measurement. Remember, when you are measuring range of motion, you have to have two numbers. You cannot go straight to the movement and measure the last or the finished product. Why? Well, because you didn't measure the starting point. You don't know if it's 0. What, you gonna assume this is 0? You can't. You have to measure the 0. So measuring 0 is actual measurement. And it's important one too, right? So we measured that 0, and now we know it's 0. What I'm gonna do now, I'm gonna take the finger, I'm gonna come right back as precisely as I can, because this is my axis of rotation. Yes? I'm gonna put the goniometer down for now, so don't put it far, for now. Now, very important step, which a lot of people don't remember to do. Even pay attention to your CIs in the job, your job where you work, might not remember about this step, because I saw that so many times with experienced therapists already. So chances are that even your CIs don't remember about that step. You have to stabilize above the joint being measured. And I'm gonna explain it to you why. It's very important that you stabilize above the joint being measured. So in this case, it's gonna be what? Distal to the shoulder, but proximal to the elbow, right? Low, near the elbow, but never on the elbow. Why? Well, for a couple of reasons. First, you're gonna immobilize the elbow. And secondly, if something wrong with the elbow, you're gonna cause unnecessary pain and discomfort, right? So never press on the joint being measured, always above the joint being measured. Very important step. Okay, so now I got my stabilization. I am still marking my axis of rotation. So, ma'am, can you just touch your left shoulder with your hand, please?
Yes,
Just go ahead. There we go, and stay there. So now, I stabilize. I know that she didn't do any accessory movements. No cheating was allowed because I would catch it and I would then ask her not to do certain things, right? So I'm still here. So now I do not need to stabilize anymore because she already did the motion. She already did it, right? So no stabilization needed. I can retake the goniometer and reapply the goniometer. The fulcrum of the goniometer on the axis of rotation, which is lateral epicondylar. Stationary bar next to, parallel to humerus. And the movable bar parallel to radius. Remember, how do I know that it's parallel? Well, I know the bones. I know how the bones should go. I know that the bone is inside of the extremity. And the black line, the black straight line in the middle of the arms, that's what I'm taking into consideration. So you do not do, for example, this because you think it's a midpoint of the wrist, and then you can see that those lines actually cross. Can you see that? They have to be parallel. So the bone goes like this, the line goes like that, pretty good. Okay, you can relax. And now, what's normal for elbow?
135.
0 to 135. 0, yes. How much is it? How much? What? To what? I can't hear you. 0 to
135.
where did you get 135?
No, that's the normal.
Yeah, who was this over here? Which scale are you looking at? All right. Yes. So, okay. What's the number? Remember, what's normal? That's why it's so important. How much? Okay. Was she normal? Did she appear normal to you?
Yes.
So look for that closest number to what you already know. 135 is the number. Where is she? There we go. All right, there we go.
Yeah, like 141.
Okay, but you know the number, right? Yes, you know what the number you're looking at. Right. 135 is the number. Why would you look at the 40? Was she 40? She appeared normal, right? Why would you even bother with any other number? Well, it's 142. That's what it shows. 142 is the closest to normal, and you saw that she is normal. Make sense? Guys, you got it? Okay. All right. So, so that's that. And now, why the important aspect? Why are we stabilizing? Well, if let's say I want drink, I want to take a drink, simple activity like that, right? But my shoulder doesn't work well, right? So, but I'm gonna ask my patient, oh, can you take I want to assess ADLs, right? I want to assess self-feeding. Can you grab the cup and take a sip? And the patient is like, yeah, I'm actually thirsty, I can take a sip. And he's gonna grab the cup and he's going to do this, right? Yeah, it's total compensation. How am I measuring? What am I measuring? I'm not measuring anything, right? It's so, this actually is so complicated biomechanically, right? And it's wrong, but it's also very complicated. And what am I actually measuring, right? So you have to measure what needs to be measured. So your stabilization shows you, it's not like you're gonna fight with her, right? But you're gonna feel, and then you can stop and say, please don't do that. All I want you to do is this. You can do it, fine. You cannot do it, just don't do it. Just tell me or show me what you can. That's all I'm asking, right? So we're gonna eliminate that extra movements because otherwise we will have very wrong numbers, like we are not doing what we're supposed to do. Does this make sense? Okay. And it's enough to give her or him, whoever is your patient, tactile input. Sometimes just touch is enough for them not to move. But sometimes it's not enough, and then you're gonna stop and say, no, that's not what we're doing. Please, refrain from that, and we're gonna start over. All right? Make sense? Awesome. All right, supination, pronation. Patient sitting, or standing, or laying down, or whatever. Just remember, guys, if you know.
I just had a flu shot there and you keep patting it.
Oh.
So every time you pat it,
Yeah.
but it's okay.
Oh, that's why you are so jumpy.
Yeah, I'm sorry. I realized I should have gave you this arm, but that's okay. I'm okay.
No, because I realized that you're very jumpy, and I'm like, what happened? Like, am I electrocuted?
Static.
I'm sorry. I didn't put two and two together.
Right,
Yeah,
right.
sorry.
No, of course. Now I will pay attention to it. Okay. So remember that once you know how to do it, it doesn't really matter if she was laying down, we can still do the same thing. If she would be sitting in the wheelchair, so what? She's still sitting. See what I'm saying? It really doesn't matter as long as you know what you're doing. Yeah.
So for the test, is it going to say the positioning on the paper, or do we get to choose?
No, you're gonna choose. You're gonna choose. You can do it whichever position you choose, but correctly, right? Whichever position it is, it
So we
has
just
to
tell the
do
patient
what.
to get in the position?
Correct. You're gonna inform your partner, which in that case is gonna be your patient, what to do, and they don't do anything unless they are informed what to do. Okay. All right. Good question. All right. So patient, in this case, we're gonna do sitting, right? Humerus. Abducted. Okay, so when you are piggybacking or your question, when you are coming and for the test, there is a protocol, as you could see. You're gonna notice it's a protocol. It's position first. It's finding the axis of rotation second. It's measuring the 0 point. It's then lack of words, stabilization and movement, and then reapplication of goniometer, and then final reading of the findings, right? So it's a protocol. Those are steps. So just keep those steps in mind, because those steps do not change. They don't change. Okay? So let's start from the beginning. What's the first step? Positioning. So what's the positioning? And that's so when you are being examined, you talk to us, you talk to me or Dr. Domville in the professional language, meaning this language. When you turn and you give directions to your patient, layman terminology, right? Layman terminology, because I don't expect my patient to know what supination is. They might know, but I'm not going to take it for granted. Like, to supination. What? How can you not know what supination is? I'm offended. So you're going to talk to the patient like they are your patient, and then you're going to talk to us like this.
Okay.
Yeah, you might. Yeah, that's what I do. That's the easiest. Do this. Yeah, and they, absolutely. All right, everybody with me? Okay. So, patient in sitting, humerus adducted, elbow at 90 degrees, forearm in mid position. This is the position, and this is how you're going to describe month from now. All right? Step by step, just like I did right now. Okay? Place a pen or pencil, which I do not have. Anybody can?
Yeah.
Oh, thank you very much. Okay, I have to go on to the other side. I'm sorry, I apologize for this, but there's no way around it. So, you can just so you can see us. All right. So this is like the pen or pencil method. There are different methods, and especially in the hand clinic, outpatient hand clinic, they usually do a little bit different. They usually do this way. All right, but in order to not to confuse you, and let's face it, how many of you is going to work in the outpatient hand clinic? Maybe one, right? As our entire group. Majority of you are gonna stay either in peds because you already love it, right? Half of you works in peds. She's like, no. But and the rest of you is most likely going to work with adults geriatrics, maybe some acute settings, maybe some rehab, maybe some this, maybe some that. But not many of you is gonna end up in outpatient hand clinic, because then you have to have the certification of a hand therapist, and that takes like
5 years.
long time. Yeah,
5 years.
Yeah, it takes time. And some of you might be like, heck, I don't like it anyway. That was me. I didn't like it. I was in the hand clinic for my second rotation or first rotation, maybe. I don't remember. For my as a student, I went for 3 months in the outpatient hand clinic. And after that 3 months, I was like, nope, not for me, because I am too outgoing. Like I need to be everywhere, and here I am, 8-9 hours a day, confined to the corner of the gym, like confined. And all I do is pretty much. You might think that it's variety, but actually it's less variety than you think. It's like hot pack, cold pack, massage, fluidotherapy, exercises, some gliding exercises, and perhaps some splinting. And that's it. That's all. That's all. Those my 3 months. And I was confined to this. And the number of people, oh Jesus Christ, like constantly. You don't have like a 5 minutes break. And then they come to me and they lie into my face. Liars. And I'm like, you're lying. I couldn't say it, right? But in my head, you are too old to lie to me like this. It's like why? But you know, because half of them were workers' comp. Big guy or looking like him. Right? Comes and goes. What happened? Oh, the box fell off my hand, right? And like no redness, no swelling, like no nothing, right? It's like, where does it hurt? Oh, here. But last night was here. Like, are you serious right now? Like, are you 5 or are you 45? I can't say that, right? But it's like you lying into my face because you want the insurance money, right? And then it's like, but half of my patients were like this. You know how disgusting this is? And then I was like, okay. So I said, okay, let's start with hot pack, right? Okay, hot pack. Then the fluidotherapy with some exercises. Okay, let me massage a little bit. Like,
Yeah.
like him. Are you serious? Are you serious? Anyway, the next time he comes, like, oh, the pain moved from here to here. And I'm like, you know, if I was your mama, I would slap you. It's ridiculous. It's ridiculous. So I was like 3 months. I was like, and they asked me to stay. I was like, oh, do you want to stay? They like me apparently for whatever reason. I was like, oh, you want to stay? You want? I was like, no. Like 3 months is more than enough. So anyway, yeah. So it's true story. True story. So anyway, so I'm gonna read it again so you know that I am serious about these pages, okay? Patient in sitting position, humerus abducted, elbow at 90, forearm in mid position, right? Which is this. We're gonna give her a pencil, and the pencil must be perpendicular to the floor. Everybody understand perpendicular, right? This is perpendicular, this is horizontal, right? Perpendicular is always against gravity. We're going to learn this tomorrow. It's always against gravity. Parallel is less gravity. There is always gravity, by the way. Always gravity. It's just less gravity, which for easiness of discussion, I'm going to call it no gravity. But just so you know, there is no such thing as no gravity. Okay? It's just less of it. Okay, but that's discussion for tomorrow. So let's focus on today. All right, so find the pony landmark. What is the pony landmark? The third MCP. The third one is this one, right? Because 1, 2, 3, right? So that's the third one. So find the pony landmark. Place the fulcrum of the goniometer on the axis, stationary bar perpendicular to the floor, and the movable bar parallel to the pencil. That's why we have the pencil. Okay? So fulcrum of the goniometer on the axis of rotation. Stationary bar, where was it? Perpendicular to the floor. That's gonna be the stationary bar. Where is the movable bar? Parallel to the pen, and that's why we have the pen. Now pay attention that the black line in the middle of the goniometer does not match the pen whatsoever. That's what I said. It doesn't have to overlap. It's your job to have your eyes right here, not below, but on the level. So now I can see the black line and the pen and make it parallel. You see that is parallel? Yes, am I right or no?
Yes.
It is parallel, yes? Yes, parallel? Yes, parallel. Not like that. Parallel. Okay. So we have 0. That's very easy. That I don't know anybody who wouldn't have 0, because that's a very easy position to get the wrist to. But we're not going to take it for granted. So we're going to measure it. And I measure it, and it is 0 indeed. Can you see it? Okay. So I'm going to replace the same procedure. I'm going to replace the fulcrum of the goniometer with my finger. Take it away. I'm going to switch it because this way, right, is easier for me. What am I going to stabilize?
The elbow.
Above the elbow. Remember? Because otherwise, what am I measuring? Where the supination? I'm sorry, can I just put it? Tiring. So supination and pronation occur in what joints?
In the wrist and elbow both.
Yes, elbow and wrist together, right? If one is affected, then affects instantly the other, right? So if I am going to put my stabilizing hand below the elbow, well, that's not going to work, because we just said that the elbow works for supination pronation. What did I say? We're never going to put our hand on the actual joint. So where else is there? Right here. Right here. It's logical, isn't it? Yes. So stabilization goes where? Proximal to the elbow, but distal to the
shoulder.
Yes. So right here. Good. So now, would you please do this motion as far as you can? Okay, go for it. All right. So she did it. Stabilization, not required anymore because she already moved. I'm gonna just simply reposition the goniometer, okay? So fulcrum of the goniometer on the axis of rotation. Again, my eyes needs to be here, okay? Stationary bar, perpendicular to the floor. Movable bar, parallel to the pen. Now, which way I'm gonna go, left or right? Right, because I screw up.
Supinations.
I didn't see it this way. Okay. Yes, because she went into supination. So I'm gonna follow the supination. Okay, so I'm following the supination. And again, my eyes have to be very, very on the mark because I will miss the. Okay, good. Thank you.
Yeah.
What's the norm? What is normal?
70.
0 to 80.
0 to 80 to 90,
Yeah.
right? And what do I have here?
9.
Okay. What do I have here?
90.
Oh, 90.
Ah, all right. You see that? See the numbers? You found the 90? Okay.
Yes.
But you know that this is the 90, right? Not the other numbers. You know why this is the number, right? Okay, good. All right, everybody good? All right. Pronation, we're not gonna waste time on the pronation because it's identical. So basically everything what we showed you is identical, except that instead of supination, you're gonna go into pronation.
Palms down.
But the whole thing is the same. So I'm just gonna leave it as is, but you practice both. You practice both, but it's identical. Okay? Okay, so we're gonna not do that. Okay. So now we're done with the elbow, so let's go back to shoulder. Okay? And again, I started with the elbow because it's kind of the easiest for me to show, to kind of start you off. Because shoulder, it's a little bit, in my view, maybe a little bit more complicated, maybe not. Maybe that's just my perception. I don't know. But anyway, I don't think we need that anymore, so or we will. No, we won't.
No, we won't need that.
You good?
I'm good, sir.
Yeah. Okay. Yeah. Yeah. Okay. Yeah, but yeah, you. That wasn't a good idea to go for a shot today. No?
That later, okay? That conversation. I do have another body part that works fine.
Just saying.
All right, so.
See, you think you get tortured by him.
Yeah. Sometimes the story about your daughter's birthday. Yeah.
Oh my gosh, my daughter turned 1. Was it 1? It was
Yeah,
her
it was,
first
yeah.
birthday. And I asked to leave early, I think.
Yeah.
And he says, yeah, but is this going to happen every year? So I make sure in January I plan her birthday, which don't worry, it's not on the day that we're having kids. I made sure. You get his sense of humor at some point.
Yeah, sometimes it's weird sense of humor. Not always appreciated. So let's put it this way. All right, shoulder flexion. Patient, sitting, standing, laying down, doesn't matter, right? For our purposes over here, it's going to be sitting. Forearm in neutral, forearm in neutral. So what that means? Well, no, that's
Anatomical is.
that would be anatomical position, which is not neutral. No. So what's neutral? It's here, right? There we go. So that's neutral, right? Anatomical position doesn't mean neutral. In fact, there is very little neutral in anatomical position. All right. So don't mix those two. Anatomical position is your point zero when you're describing, for example, body parts or body positions in space. But it does not mean that anatomical position is equivalent to being in neutral. because there is not much neutral in that. Okay, my shoulders are abducted, my elbows are extended. See what I'm saying? So, no. All right. Where am I? Okay, here. Okay, neutral and humerus adducted. So this is how you're gonna say it during your exam. Okay, this is how you're gonna learn. This is how you're gonna practice. All right, find bony landmark. What is the bony landmark? You have it right here. Humeral head. Okay, it's fun to find it.
Oh, yeah.
Especially when you had the.
No, it's
flu
not
shot.
there. No, you're fine there.
Okay.
No matter what.
Okay. Yeah, it's fine. Yeah, it's fun to.
He likes to emphasize where it is. Watch when he's talking to you guys, and he just doesn't realize that he's like choking the whole time. Well, you'll see.
I'm completely aghast right now. All right. So how are we gonna find the? We have to find the bony landmark, which is the head of the humerus. All right. Head of the humerus is not easy to find. And why is that? Because, well, I'm going to kind of show you on my hands. It's not perfect, but at least something. So let's say that this hand represents scapula. And let's say that this hand here, this represents humerus, and this is head of the humerus and the humeral head. Let's just assume that, right? So this is how we are built. This is how that look like, okay? So find the head inside that structure here, which is our shoulder. It's not that easy. Now you have flesh over here and muscles, right? Flesh and muscles over here. So the head, it's pretty deep. Pretty deep, right? So you're not gonna palpate the head. So we have to find a way of educated guess. Is it gonna be educated guess? By the way, is goniometry and manual muscle testing standardized or non-standardized test? Okay, shaky on that one? All right. Good try, but not necessarily fully correct. Okay, so I'm going to tell you, standardized is no matter who does it, or when does it, or where does it, or what part of the day, in the morning or evening, or whatever, the results are going to be the same. This is standardized test.
Oh, thank God.
What did we say?
Because I put
What
it in
did
my
we say
discussion.
about range of motion in the very beginning? That what we recommend? The same therapist does at the same time of the day, using the same goniometer. What does this tell you right away? It's non-standardized. It's non-standardized. Now you are going to learn this way, which is, by the way, a very appropriate way. And then 2 years down the line, you're gonna look for shortcuts. How can we call this standardized test? How your colleague who does this a little bit differently, or forgot from school how to find the appropriate bony landmark, how you expect to have identical results? You're not going to have identical results. Now, if the difference is up to 5 degrees, then okay. But if the difference is 30 degrees, well, definitely somebody doesn't know what sure he's doing, right? Definitely one of you is wrong. Right? So either you or somebody, but 30 degrees, no, somebody's wrong, right? If I got 5 degrees, I can live with that. So now you know that this is a non-standardized test, yes? Because of the skill, your skill, and your experience will dictate how accurate your measurement is. Am I making sense? Okay. So, how are we gonna find the bony landmark, which is head of the humerus? We said already, right? I showed you. It's not that easy to find, and we definitely not gonna palpate. It's too deep. It's covered with muscle and joint fluids and some ligaments, and you're just not gonna poke it that hard. Right? You okay? You can see it? Yeah, if not. So how are we gonna do it? I'm gonna palpate for clavicle. I'm gonna palpate for the superior aspect or superior border of the scapula. Yes? I'm gonna go on the top of both, and where they meet, right here, it's called what? Acromion process. Acromion process, right? So I found the top of the junction of scapula and clavicle, thank you. So it's gonna be acromion process. So now what? That's not the head of the head is lower, right? The head is lower like this. So we're gonna go, no, are you gonna be in pain?
No, it's right here. This
Yeah,
is where
but-
it is right here. You're not palpating there.
Okay,
Right here.
all right.
It's right here, look. I'll put my hand
Oh yeah,
there,
push
okay?
on the
Yeah.
Yeah. So now I'm going to palpate for you're gonna feel, I promise you, you will. You're gonna reach the point that the hard surface ends and the soft surface starts, and you're gonna have like a dip. I call it dip. That's just my name for that, but it's okay. Okay, so hard, 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 boom, boom, right here, right here. Yeah, dip. Dip.
She's tapping you right there.
Come on, doesn't hurt.
No, it doesn't hurt. Not at all. No, it doesn't hurt. It's fine.
So you're gonna feel the dip, okay? So this is where we have the head of the humerus. How do I know this? Again, if you know your anatomy, you know that if this is scapula and this is the humerus and this is the head, it's going to be like that. So you are hard, 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 dip. You know that that's the approximate place where the head of the humerus is going to be. It's an educated guess, but it's pretty accurate. Okay? So I got it. I got it. You have a question?
Is it that where subluxation occurs?
Well, that's a different story. If there is subluxation, you don't do those measurements. You do not do range of motion or manual muscle testing with subluxation. You got different problems.
Yeah, it'll feel different. It'll look
Yeah,
different. Yeah.
with subluxation, you're gonna have, first you have to take care of the subluxation, right? Especially post-stroke people, right? You do not do manual muscle testing and range of motion on post-stroke patients. Why? Because it's not biomechanical approach. It's a neurological approach. Completely different frame of reference. You do not do range of motion and manual muscle testing on brain damage because it's a biomechanical. On brain damage, you do neurological, you do rehabilitative, you do different frameworks, but not kinesiology doesn't work with brain damage. And traumatic brain injury, stroke, this is all brain damage, right? By the way, that's a part of the very first, I believe, PowerPoint, right? So you better know this for tomorrow. So I got my head, right? Okay. Now it's time to put the goniometer. So you tell me now, guys, where the fulcrum of the goniometer goes?
Axis of rotation.
On the axis of rotation, which is?
The head of the humerus.
Come on, guys, bear with me. Yes.
Head of the head.
Now, stationary bar goes where?
Parallel to the trunk.
Parallel to the trunk. Movable bar goes?
To the humerus.
Parallel to the humerus. So in normal, and I always do this kind of, air marks, normal, because we already discussed that normal is kind of fluent, right? But we're gonna call it normal, right? In normal, they're gonna be parallel to each other. So students make those couple of mistakes. They're gonna describe this as the bars are gonna be parallel to each other. That's mistake. The other mistake is it's gonna be the stationary bar is gonna be parallel to the humerus. Another mistake. Why? Because if she doesn't have 0, if she's gonna be stuck over here, then we're gonna put both parallel to the humerus as you said it, and what did I measure? Nothing. If it's parallel to each other, I measure nothing. If it's parallel to humerus, I measure nothing. So the proper way of understanding this is parallel to the trunk. So if she cannot fully go into neutral, I can catch it. I can catch it, and it's not gonna be 0. It's gonna be, let's say she's stuck in this position due to the arthritis. And she's stuck, so I captured that. So how would you document? Instead of 0 would be what? Negative or just 18? Just 18, very good. Right? Yes? Right? So she started off like that. So the number is 18, not 0, 18. But we have to know this, right? So that's why the first measurement is so important, because we have to know this. It's not gonna be 0, it's gonna be 18. But again, we are gonna practice with normal, so it's gonna be 0, all right? So we got our 0, and I lost, but let's pretend that I didn't. So we got our 0, right? So I'm going to replace the goniometer with my finger, and I am going to do what? Where am I going to stabilize?
Shoulder.
Above shoulder. Because shoulder would be here, and that I would...
You would block the...
I would block the movement, I would immobilize the shoulder, or at least to be on the way, so above the shoulder, okay? So I got my axis of rotation, I got my stabilization right here, and now I'm going to ask you, can you move your arm as high to the ceiling as you can, okay? Go ahead. There we go. And just stay there. Look, where is my finger? Where is my finger? Remember elbow flexion? Yeah, elbow flexion, we were drawing imaginary line, and I told you this is one of 2 exceptions that we have to do something about it, because now if I'm going to apply the goniometer, that's why we're learning planes and axis of rotation, right? That's why I ask you, and you got so many pictures and drawings and in PowerPoints and all of this, I explain it, because you must understand this, because if you put the goniometer here, how can I possibly measure flexion? Right? The goniometer must be here to measure flexion. It's a different plane. It's a different cardinal plane. Not coronal, we have to go to sagittal. So how am I going to accomplish that? The same way I did it with elbow, right? So my eyes on this, and parallel line, parallel, not down, not up, parallel to the floor, right here. So now I know that right here is what? The head of the humerus. The head of the humerus. I'm reapplying the goniometer, and now you're going to appreciate what I said about the stationary bar. So, fulcrum of the goniometer goes on axis of rotation, which is the head of the humerus. The stationary bar, now you're going to appreciate this. Where goes stationary bar?
Parallel to the trunk.
You see that now? Parallel to the trunk. Not to each other, not to humerus, to the trunk. And now movable bar goes parallel to humerus. And she can do better than she got tired, of course. So it's normal, because normally you wouldn't keep your patient for 5 minutes in one position, right? Thank you. So what's normal?
170.
0 to 170 to 180, right? 0 to 170 to 180. And she had what?
0 to 169.
Mm-hmm. Yeah. Yeah. Guys. All right, 169. Yeah. All right. Okay. So is she normal, or is she not? She didn't do the normal, what you expect.
Normal.
I would say she's pretty normal, right? Pretty normal. Yeah.
My arm up there for
Right.
so long.
Exactly.
Piano.
So she's definitely normal. She's definitely functional. So that would not be your focus for therapy, right? That would be not your focus on therapy. By the way, when you see a patient, before you do any range of motion like that, right? This is what you're gonna do. This is what I do, and that you probably observe this in your clinics as well. Ma'am, can you raise your arms like this, up, all the way up? Okay, can you do it here? Good, can you touch the back of your head? Good, can you touch the back of your lower back? Good, can you do this? This again, and rest down, rest up. Can you make fist? Relax, I'm done. I'm done. Everything is good. Why would I waste my time to do all of that if there is absolutely no difference, right? For practice, yes. But other than that, like,
Yeah, they don't know, right? You got a test, I might as well take advantage of this situation.
right. But so when you're doing those measurements, when are you doing those measurements? When the situations requires you to do it. When she was in the car accident, and she got the limitations now, right? And then when you do it, right? But when there is a, let's say, cardiac patient or whatever else, right? Which is not biomechanical, and there is no issue, then you're not gonna do that. This is a specialty test, which you're gonna perform only on those people who requires you to do it. It's like a specialty test. It's not like I don't know much about pediatrics because I never work with pediatrics, but there are many pediatric tests. You're not gonna apply all of them to the same kid, right? You're gonna be very choosy, and how you're gonna choose the appropriate one? Well, according to the child needs. Not that you're gonna throw at them 100 tests because you know 100 tests, right? Make sense? Same thing here, right? Okay, so how are we gonna do shoulder extension? Everything exactly the same, except one thing. For shoulder extension, going to extension, we don't have to draw an imaginary line. Why? Because it doesn't change, right? Look at this. We are here, and now go into extension, and we're still here. Didn't change. But go into flexion. There we go. I'm all the way to the bottom, right? So with flexion, I have to draw imaginary line. No, it's fine. I have to draw imaginary line. With extension, I don't. But what's normal for extension?
0 to 60.
There we go. 0 to 60. And everything else is exactly the same. Okay? So after our demonstrations, you're gonna practice for the rest of the day. You're gonna practice this on yourselves and take advantage of the time. Just practice, and then we are going to be present, and we are going to walk around, and then you can ask us any questions you might have. Okay? But so that's that. What next? Shoulder abduction. So again, there is no neutral for abduction. So what you have is either adduction or not. Right? So if I am touching my side, I am adducted. But if my arm does not touch my trunk or my side, then must be abduction, right? Because there is no neutral. So I'm here, I'm slightly abducted. And here I'm like halfway abducted or whatever, and here I'm extensively abducted, right? So abduction, adduction. So again, in the movie, when you're filming somebody, they can go from abduction towards adduction, or from abduction, or from abduction towards adduction. That's what happens in the movie, right? But if you're talking about a still picture, it's a still picture. It's either this, or is this, or is this, or is this, or is this, whatever, right? So this would be adducted, but here would be already abducted because it's a picture. It's not a moving film. Moving film, then you would describe differently. You would say from adduction to abduction, or the other way around, from abduction towards adduction. But we're not describing film, we're describing a still picture for your assignments. So keep that in mind, okay? It's one or the other, not 1, 2, or 1 / the other. And what am I looking at? I'm not looking at the film, I'm looking at the still picture. Okay, so sitting or standing, my partner decided to sit, fine with me. Forearm in supination, forearm in supination. Okay, and why is that? Why positioning is so important? Well, let's do experiment. Everybody, let's put your one, left or right, doesn't matter. Let's put it in the full internal rotation, shoulder internal rotation, or forearm pronation. Full, like even more than that. Yeah, that's good. Like as much as you can. Now for this position, straight up yourself, nice posture, and try and perfectly in coronal plane. Try to raise it as high as you can. As high as you can, as high as you can. Okay, now put it down. Now reverse it. Let's put it into external, shoulder external rotation, or forearm supination is the same position, right? So here, and now bring it up. See the difference? That's why the positioning is so important. There is not because we want to be mean to you, and we pay attention to details. We pay attention to details because they are that important. Okay. So, Bony landmark, posterior side of the acromion process of the scapula. Place the fulcrum of the goniometer on the axis, stationary bar parallel to the trunk, movable bar parallel to the humerus. Take first measurement, then take off the goniometer, of course. Then you're gonna stabilize and reapply the goniometer, do the final measurement, and you're done. Right? So let's do that. So posterior side of the acromion process. So we already know where the acromion process is or how to find it. We already did this, right? Remember clavicle and the superior border of the scapula. Where they meet over here, that's the acromion process. But this is the lateral aspect of the acromion process, which we're really not interested when we are talking about abduction. So we have to go back, right back to the posterior side of the acromion process, which is posterior. It's going to be here. So I found it. I'm going to apply the goniometer. Now, this is one of those exceptions that the fulcrum of the goniometer is not going to go directly on the axis of rotation. Why? Because I'm going to end up with goniometer looking like this. What am I measuring? That's not the plane. That's not the frontal plane. That's a mixture of planes, right? So I cannot do that. So in other words, I'm gonna stand, normally I would stand right behind her. Remember, nose and toes in the same direction, and I'm facing what I'm measuring, right? So I would be here, but you cannot see anything. So for your sake, I'm gonna stand over here, okay? But the goniometer, it's gonna be